Hi, everybody.
Cool.
Thank you for joining us. My name is Raf. I'm the Chief of Staff here at Astron Health. For those of you who aren't familiar, Astron is a precision oncology company where we essentially analyze each patient's molecular drivers against all of peer-reviewed research to identify the most well-evidenced and ranked treatment options specific for these patients. Today, we're excited to bring together two leading voices in the metabolic oncology space. Dr. Nasha Winters, author of the Metabolic Approach to Cancer, with over 30 years of experience in terrain-based cancer care, and Travis Christofferson, author of Tripping Over the Truth, with a background in molecular biology and metabolic cancer research. They'll be exploring the metabolic terrain, how it intersects with molecular data and precision oncology, and what that means in practice. As mentioned again, please drop any questions in the chat or save them for the live Q&A at the end. And with that, I'll hand it over to Travis and Nasha.
All right. Thank you, Rob. Thank you,
Thank
Nasha,
you.
for doing this.
Yeah, thank you guys.
Yes. So we go back, 2014, you and I met at an obscure conference in, I think, Reno, Nevada.
Yeah.
And so we have quite the arc of watching this unfold over a decade. And so the focus of this today that you and I talked about, we want to talk about the absolutely critical importance of this sort of comprehensive package for cancer patients and what they need to know about. The sort of convergence of what you've spoke about and what you're the thought leader in of what you call the terrain. So the preparation of the body, the importance of the state of the sort of the milieu that cancer is existing within, which has been hugely underappreciated. And now it's fascinating because more and more studies have really validated what you've been talking about for over a decade. And then also how this sort of converges with the precision approach to oncology and what Astron is doing to expand precision oncology and how those two exist together. But let's start with something, I think you and I both love is, and what adds so much perspective is that narrative arc of the clumsy history of medicine and specifically, especially with regard to cancer, because I think most people, what they feel in the time they exist in is that science is mostly settled, that we're always at the apex of where we were before.
Right.
But when you extrapolate that arc, you will look back and you'll realize that, especially with regard to cancer, we are still stumbling, and we could be doing so much better, specifically with regard to using the existing medications that we have and the existing data. So let's start there, Nasha. Let's go back to go wherever you want, but you know how I love the history of medicine and what, how it drug its feet for so long, and go back to where cancer, wherever you want to start and where we have arrived today.
Well, first of all, Raphael did a beautiful job introducing me, but I have been a fangirl of yours for an incredibly long time. That's why I stalked you in the line at that Reno event. And you were surprised that somebody knew your book. This is before your book got picked up and brought out into the bigger world. Your words spoke to me, Tripping Over the Truth. For those who've not read this book, it's still as relevant, if not more so today than ever. And then you've run several other books beyond that, really breaking down the history of the healthcare or disease management system of medicine and diving deep into Krebs' cycle and Dr. Krebs' work and the historical perspective. That's probably where we really relate, Travis, is in our passion for context and our passion for history. And so to your point, the story specifically to cancer for us in this conversation today really started in 1914 with Dr. Theodore Boveri, who really laid sort of claim to the concept that cancer is a genetic hiccup, that it's just a somatic mutation disease. And it was interesting because that was in 1914, and a few years later, you dive deep into this into your books, and people like Dr. Sam Apple dives deep in the book Ravenous on this topic. But another thought leader and scientist of the time, Dr. Otto Warburg, came out saying, wait a minute, maybe genetics are a downstream effect, not the beginning point. And his work actually really took off and ran up until the 1950s, when a couple of guys took credit for some women's science work to claim to have found the DNA helix. And we quickly reversed our ideas and our approach back to Boveri's original thoughts from 1914 and virtually ignored everything of Otto Warburg's time. And I think Sam Apple does a good job in his book as to maybe why that was. This may have been more politically or culturally motivated versus scientifically motivated. But that's what you and I, when our paths crossed in 2014, and I learned of Dr. Tom Seyfried in 2011. And I learned of other people's work like Dr. Mina Bissell from the 1980s and the early 90s during my own diagnosis, to realize that, cancer wasn't necessarily starting at the genetics. That was more of a downstream expression. And I feel like this crossroad of our conversation today is, how do you take the best of genetics with the best of the extracellular matrix or the environment or the terrain or however you want to describe it, and bring those worlds together? Because I think we did a disservice when we threw out basically mitochondrial metabolic health in the 1950s when we found the helix, but we also do a disservice when we completely ignore the genetics. We just need to think about them and ask different questions. And I think this data research, milling platform is what helps bring those worlds together.
Yeah. And there was, when you read the history, right, there was a stark line drawn with the discovery of DNA, because it was just this, oh my God, this is what's running the cell. This is where all the information was. When you read those papers at the time, it was that Warburg just didn't get it, right? That he didn't appreciate how important, and Hans Krebs was kind of the architect of a lot of those papers, his #1 Nobel Prize winning grad student. So it's a fascinating history. And then it got, and when I was in school in 1995, that's when I think they began talking about the Human Genome Project and how this map was going to, and Clinton gave an address in the White House lawn, right? This was the equivalent of the Columbus map, that we would finally know the origins of every disease. And he even mentioned diabetes. We would find the genes for diabetes here. This would lead to cures to all diseases, was his quote. And then when you fast forward, you realize there's a ton of information in the genome, but a lot of it is not that important as we thought. There's so much more going on in the background with metabolism and the epigenome, and these diseases are so multifactorial, especially cancer. And so we fast forward to the Cancer Genome Atlas Project, right? And that's when when I was writing my book, that data was spilling out, and it was just absolutely confusing everybody. We thought we'd see this perfectly tidy series of genetic mutations that would lead to each type of cancer. And the clinical data led to that belief, like colon cancer would slough along, and specific mutations would sort of underpin that progression from polyp to, stage 1 and metastasis. But the Cancer Genome Atlas data didn't show that. What it showed was more confusion, extreme heterogeneity from one patient to the next. And suddenly people are revisiting cancer and trying to reconcile what seemed like settled science with the somatic mutation theory with all of these, this confusing data. And so that's when you kind of stepped in and realized the importance of terrain. And when you talk about terrain, give us a little more. So we talk about nutritional status. I mean, you can manipulate the metabolism of the human body so many fascinating ways: fasting, different dietary strategies, exercise. So yeah, talk to us about the terrain.
For me, just from my own diagnosis back in 1991, although it would be another 5-6 years before I recognized there was, in fact, a genetic component. I learned about my BRCA status, as one of the early adopters of the original testing in that arena. And then later, another, 8 years later, I learned my single nucleotide polymorphisms. And so data has been really important to me, as like understanding my own body to help me understand my own process, but also to help me understand that of others. But what I still found to be true back then, and even frankly more so today, is that it always comes back to this terrain concept. So what is the environment of the body doing? What are the conditions that allowed this cancerous process to take hold? We've literally spent decades focusing exclusively, if not almost 100 years or longer, exclusively on the tumor and the tumor metabolic pathways. But we haven't really understood. Well, I'll diverge a moment here. We've started talking about these concepts of hallmarks of cancer also in the 2000s, and it's iterated a few times up from then until what most recent was in 2022. We've expanded on a little bit, but even the hallmarks of cancer do not explain why they express. And so no one's wanting to understand, well, why is there a loss of apoptosis? Or why is there a metabolic shift? Or why is there a proliferation issue or a DNA repair issue? No one is really asking those questions. So that's what I believe the terrain approach does, is it looks behind even those hallmarks or even beyond those single nucleotide polymorphism expressions or those genetic expressions that shows us the conditions in which those things were able to express. And so that could be, as you noted, things like inflammation, but what's causing the inflammation, right? Or poor oxygenation. Well, what is that about? Is that about you not being an active mover of your body? Do you have an obstructive airway disorder? Do you live at high elevation? I mean, there's questions beyond questions beyond questions to each and every one of these concepts. And so when I developed this Terrain 10 way of sort of organizing the way I see things, a framework just to ask these better questions, that's when I could start to dig deeper, that it's not just about what's the tumor doing, but what's the terrain doing. And because when you shift that lens, really everything changes and you start to see these connections, this interplay. You can't silo it off. And you also don't then have good success when you see a single target and a single treatment. You might see a little movement, a little dial move, but you're not really getting the impact that you're hoping for. So what we can do coming through the terrain lens is we can start to see the upstream drivers that allow the tumor model to express. And it shows us maybe what we're missing in this area. And so, just a quick overview. These are things like your epigenetics, your metabolic drivers. Basically, what is the fuel source? Are you predominantly a carb, loader? Are you predominantly fat? Are you predominantly protein? And then what are the qualities and the timings of those inputs? And then we can look at your toxicants, how those are impacting you. And they're going to behave differently in you as they would with me. So for instance, my husband, he loves the smell of diesel. But for me, I get an immediate headache. Like, it's crazy how sick I can get just from one waft, but I've got some glutathione SNPs that are completely gone in my body. And so I don't process those chemicals as readily as he does. He's like a turbo processor. It's kind of not fair, but that's just the way it is. But then things like our microbiome, you and I talked about this at length, that we'll touch on here in a moment, and how critical it's playing in all of this conversation as well. But hormones, inflammation, immune function, oxygenation, circulation, circadian rhythm biology, and even stress response and mental emotional impact. So trauma impact on even how we are geared to handle the stressors of our lives and handle even the physiologic stressors of our lives. These are the things that really help us determine which patients are going to respond really well and which ones will not respond as well if you don't tend the terrain simultaneously while you're tending the tumor.
There's so much there. And I'm glad the way you brought that in, because the emergence of immunotherapies, right, which is kind of the new kid on the block. And now we're just starting, and I want patients to really know this data. And this is part of Astron's sort of second push, is all of this sort of non-standard retrospective and clinical trial data that on nutritional status, on all these things you just talked about, and how profoundly they affect outcomes. And this is not groundbreaking stuff. It's stuff that is searchable and it's there. You want to make sure, the trials are done correctly. But it's shocking to me how much exists today. And you and I talked about this last night. Okay, let's just talk about immunotherapies, so checkpoint inhibitors. We now know from collaborating trials that vitamin D status is a huge factor in people getting immunotherapies. If you're low, and this was a randomized controlled trial, 2,000 IUs of vitamin D versus placebo, while undergoing neoadjuvant chemotherapy. The pathological complete response rate, this is in breast cancer, goes from 43% to 24%, just on a vitamin D pill. Now, when you're talking about immunotherapies, this was in non-small cell lung cancer, 214 patients. Vitamin D levels were tested, and they were giving, I think, 1,200 IUs a day, half the patients, and the hazard ratio overall survival went from 91% in the vitamin D group to 48% in the placebo group. That's astonishing. That's a doubling. So,
and that's a small dose of vitamin D.
Right. So that's vitamin D. And now let's talk about, like you were talking about, hormonal status, time of day. If you get immunotherapy in the morning versus the afternoon, again, close to a doubling of response rates. And why is that? I mean, your hormones are fluctuating throughout the day, right? We probably don't have a specific answer, but it's something to do with the changes in terrain. Two well studies on just the addition of fiber to the diet, which changes, obviously, the microbiome, tremendously impacts the response rate to chemotherapy, to immune checkpoint inhibitors. So these are relatively new studies that just so absolutely profound.
Yeah.
This, these things you're talking about change outcomes, yet are really not on the radar. I just looked up before we got on, is it standard of care to give immunotherapies in the morning yet? No, there's not enough. There's conflicting or not enough data. And these are extremely well executed trials,
Wow.
So
Yeah.
this is what we want. And I think your passion is just to disseminate this sort of information so people know. It's shocking to me they don't know about it.
Well, and it's interesting, the other thing you and I talked about is one of my colleagues who actually wrote the foreword for the mistletoe book, Dr. Luis Diaz. He was the primary investigator when the U.S. U.S. based mistletoe trial began, and then he was recruited to and began being the head of solid tumor oncology at Sloan Kettering. So this is a brilliant dude. And one of the things I really appreciate about Dr. Luis Diaz is early on, he was very passionate about metabolic health and metabolic approach to cancer. He was very passionate about single nucleotide polymorphisms, immune therapies. I mean, he was just already ahead of the curve. That's why they did a good job recruiting this guy. But his paper became really famous when everyone was giving credit. He took 18 patients into complete response with Keytruda, and everyone around the world, I got hundreds, and so did my colleagues, got hundreds of messages from people basically begging us to put them on Keytruda or find someone who would. And what I wish they dug deeper, and maybe even what you said, Travis, like I would have loved to know the timing of that Keytruda, right? But even bigger, there's this concept known as the MD Anderson prognostic score, which was developed in 2018 to show who was going to have a better response or worse response or no response to checkpoint inhibitors, looked at 7 main factors. So their age, their neutrophils, their lymphocytes, their platelets, their lactase dehydrogenase, their liver health, and their ECOG score, so their daily function score. And basically what they found, if they had 3 or more of those as a yes, had issues with those, they were going to be less likely to respond to these drugs, as well as have higher side effects. And so one of the things that was curious to me when I saw Dr. Luis's paper on this, they were all patients young, under the age of 50. They were all treatment naive, which alone suggests that their neutrophil and lymphocyte ratio was more intact than someone who'd already been through rounds of therapy. And they also did not report, even though they were all more extensive disease, they were all probably in better health because they were not, undergoing treatment. The other side, which means their ECOG score was probably good as well. Now, what I think is really interesting about that is what you just said here is other data, like what's going on with their microbiome, what was the timing of the day. Every week, I feel like we learn something new to ask our patients. But what I've done as a clinician, and so many colleagues around the world have done as clinicians, is we've done exactly what you said. We go in and we started to dig deep into the literature. And for years, it was on us. It was on our shoulders, which meant there were very few doctors that actually had the time or the patience or the interest to do just that. And so to have the ability today in modern times today to have this at your fingertips, to have research literature mining tools that will evaluate 170,000 or more peer-reviewed publications and also then evaluate simultaneously, this is the joys of AI, 68,000 drug target pairs and, surface, how to do this. There's no amount of days, hours, weeks, months of the year that I would be able to go through that kind of information. And we could make a lot of good guesses and find a lot of stuff out there in the beginning. But I think times are changing in healthcare today that this is becoming much more automated to help us start to ask better questions and get better answers for the folks that we serve.
Yeah, that would be a perfect lead in, but we're not going to lead into that just yet because I want you to talk about one more thing about the terrain. So we talked about checkpoint inhibitors, but what I was just listening to the interview you had with your own personal story, which I know you've shared online before, to where when you got your diagnosis, you couldn't eat. I didn't realize that. And you had such GI problems that you literally fasted for 2 months.
Yeah.
And
Yeah.
you credited that at the time to, it was I think they told you 3 months is the time you had left.
Yeah.
And that's where we sort of, where I first got into this was Tom Seyfried, and how fuels and what a profoundly different beast cancer is, because it's really reliant on two fuels. And so the low hanging fruit obviously is fasting, dietary. And now we have data from Walter Longo,
Yes. Yeah.
with the fasting mimicking diet and multiple types of cancer. You see dramatic changes in outcomes. So just tell us a little bit, because that applies to everything. That's a
It
ubiquitous,
does.
regardless of treatment. Yeah.
Well, and I appreciate you bring that up, because to me, first of all, it's free, this tool.
Yeah. Yeah.
And of course, for me, it was not an intentional fast. It was a forced fast, because I had a 100% bowel blockage. And the ascites that was filling up my abdomen was taking up such valuable real estate, pushing against my organs and my digestive system, that it was just no room for anything going in without it causing excruciating pain or me just throwing up. So by default, I didn't eat. And accidentally in the beginning, I was needing to be drained a couple times a week from the ascites fluid, liters and liters at a time, to it started to lessen and lessen. Maybe I was only needing a little bit less pulled twice a week, and then only once a week, and then every 2 weeks. And then finally, in about 2.5 months, I stopped needing to have it drained. It would take me 20 some years to learn what was happening there. I was changing my inflammasome. I was lowering angiogenesis. I was giving my body a break from focusing on digestion and focusing more on all the other things that were important to keep me alive. And ironically, before the fast, I was severely cachectic. I had little tiny stick legs and giant Buddha belly, and was extremely gaunt and rapidly dying. And weirdly, you would think that's the last time you'd ever want to fast somebody. And again, this was not by choice. This was not by intellect. But what it did for me is it actually switched my metabolic machinery back into more normal metabolism. And so suddenly I started to stabilize in my weight loss, and I started to have more strength to walk, and I started to do other things. It would take me years to learn that what was giving me those superpowers were ketone bodies. But it was something that was happening accidentally, right? And yet now I can look back and realize there actually was literature supporting what was happening for me in 1991, 1992, that we're still, frankly, arguing about today in the medical field. And yet I've now had the privilege of working with, tens of thousands of patients directly, hundreds of thousands indirectly, globally, to know that this is a really powerful lever to pull. And as such, it's impacting all those hallmarks we alluded to a moment ago, all these genetics that we alluded to a moment ago, and all these various pathways, and it can enhance the response to many other therapies. I think this is where I get excited that we can finding out the data to back what we clinicians have anecdotally seen for probably millennia, but what we've definitely seen very actively in the integrative oncology community for the last 20, 30 years.
Yeah. Yeah. If you go back through the literature, it's funny how many quotes you find on fasting. Back that was standard of care for so much. And the old sanitariums like Battle Creek, Michigan, that was sunlight and fasting. And that's where they discovered that when they fasted the kids, they stopped having, if they had epilepsy, the seizures stopped, which set that array of clinical trials, the Mayo Clinic coming up with a ketogenic diet. And that was standard of care for epilepsy, this powerful metabolic tool. But then once drugs came out in the 30s, it was literally just forgotten. And that, that clumsy history of medicine where things are discovered, forgotten, replaced. And it always, comes back to this complexity bias where boring things like this just get ignored. And in a hospital setting, like boring hand washing is boring. Surgical checklists are boring to avoid human error, but they reduce the death rate by 47%.
Exactly. Exactly.
So, okay, well, let's go.
Cool.
Now this to give everybody there's so many things out there like this that are critically important to cancer care. And then the other component of this is precision oncology, which there's very good data that shows the more targets you can hit within a patient's genomic lesions, the mutations within their DNA, the better you can do outcomes. And what we try to do at Astron Health is the expansion of precision medicine. So now it's shifted now because how cheap genomic reports are, sequencing DNA. So about, I think, roughly 85% of patients in the US get genomic reports paid for. Now, the problem with that is what do oncologists do with that? When they get it, they look at it, and about 7% of those targets are able to be matched with an FDA-approved therapy. But when you expand that to drug repurposing, the whole roughly 3,000 pharmaceuticals that are approved by worldwide agencies, you can hit about 80 to 85% of the targets as well. So, and a drug is agnostic of its label, right? It doesn't know what it's what it's approved for. It hits certain targets or it doesn't. So that's what we do at Astron. And the sort of the 30,000 foot view of what this strategy is there's two types of mutations in DNA. You find oncogenes that are mutated, and that turns on the activity of that oncogene, so it drives cancer growth or other cancer-like hallmarks. So you want to directly inhibit those if you can. The other type is tumor suppressors, and when they're mutated, it's like taking off the brakes. And there's an interesting concept in precision oncology called synthetic lethality, when a tumor suppressor most typically is mutated, the cell will rely on a compensatory pathway. So if you can target that, it creates a synthetically lethal environment, and theoretically the cancer cell dies. So we're able to expand even further with synthetic lethality databases to give patients options. That, and you and I talked, the fun example that I like to talk about is the caffeine one that I've told you about so many times, because it was like a detective novel for me. Where there's a very commonly mutated gene called PIK3CA that just ramps up sort of tumor, the cell cycle, the metabolism of the tumor cell. And when you look through the drug databases, you find there are FDA-approved drugs for PIK3CA, but one of the ones that's up near the top is caffeine. And so I'm like, well, okay, so maybe there's clinical data, because coffee, it's studied a lot. So sure enough, there was a study in Sweden on 1,000 women on breast cancer outcomes and coffee intake. And when they first looked at it, they didn't see a signal, but then they looked further. They found that the women that were ER positive, that were on tamoxifen, and also had drank the most coffee, they had a 50% reduction in recurrence. So then when you go to another database, the synthetically lethality database, you'll see a strong relationship between ER inhibition and PIK3CA inhibition, which is exactly what those two drugs are doing. And so they didn't explain that in the paper or come up with that mechanism of action, but we would, according to what we do, that makes the most sense to us. So you find these sort of hidden gems like that when you're going through these bioinformatic databases.
See, and what happens to my mind when you say that is because, again, the type of things we did as clinicians for the past 30 years was best guess, right? And then we'd get another access to another tool of evaluation, and then another tool, and then another tool. And it's just like, now it's like a kid in a candy store of all these options. Yeah. But your caffeine conversation just stimulates so much for me, and that there's a particular single nucleotide. Yeah, literally. A single nucleotide polymorphism, CYP2A1. Now, you just mentioned the PIK3CA, which is actually present in over 70% of patients today, cancering patients today. And you mentioned a study of an ER-positive tumor type of women. What we also know CYP2A1 is about is how you metabolize caffeine. There are intermediate, fast, and slow metabolizers. So I'll be curious, it would be really cool to look back at those women's SNPs to see, is it better if they're slower because the caffeine stays in longer and creates a deeper impact? Is it better if it's faster, that it comes in and pings all the things it needs to ping? Sorry, there's a big truck going by right now. Or is it that there is some relationship, as you spoke to, that same pathway that is really powerful with caffeine is also very powerful with how we metabolize our hormones, specifically estrogens. And so that is super interesting to me. And then there's this, I always call them the 3 or 4 S's, the sugar, sex, stress, and sleep. Those are also the things that are going to work down those same pathways. And so it's just interesting to me. I don't have the answers, but my brain mapping is taking off to understand that we may be bringing more ahas to science, that perhaps evaluation of data like this can drive us into further research that allows us to understand the patient and not the treatment much better.
Yep. And let me give you an example. This example, like you said, kid in a candy store. How do you find these patients that are responders and non-responders? And there's so much that's where these data sets are so incredibly important. Metformin was always, people were so excited about metformin. I don't know, maybe 2012, there was a study where you saw dramatically reduced cancer rates in diabetics on metformin. So everyone got excited. How's it working? Well, it lowers blood sugar. You make that automatic connection to sort of the glycolytic phenotype of cancer cells loving sugar. They did a huge study, and this was a randomized controlled trial, 3,649 patients with high risk operable breast cancer, metformin versus placebo. No effect. When they looked further down subtype, the HER2 positive women that had this specific genetic SNP, RS112617, a C allele, one or two C alleles, so that's 70% of the population. Those women had a 49% increase in disease-free survival. So that's where this data takes us, right? And that's a known gene that affects how metformin is metabolized. So when we can get that granular and separate, all the data before was homogeneous, and we didn't know the hyper responders from the non-responders. But now, and it pains me that someone wouldn't know that. If you were HER2 positive and you just take that simple test and find if you have a C allele, what a dramatic change that would be. And that's a gold standard trial, right?
I love this. And this is where, when people say that what you and I are talking about is fringe or alternative or whatnot, it's just so wild to me because we're using really good data, really good information that help us all make better clinical decisions for the clients that we serve. And it's not about an us against them. It's like this information. I mean, you said it so perfect. Like, the data is there. Our patients are already sitting on like a gold mine that's sitting in their oncologist portal right now. And the question is, are we actually wringing out everything we can from that data? Are we even asking, are we even looking at that data effectively? And my belief is no, we're not. We're not even close. And so it's like reading the first page of a novel and acting like you know the whole story. That's how we're currently using this type of data in practice. And yet we're sitting on mountains of information. Just like for me, a CBC reveals kind of everything I need to know about where a patient's terrain is in that moment.
Right.
It's incredible how one simple test can tell you so much. It's the same thing when you said that 85% of patients have this information already sitting in their portal, just waiting to be revealed.
Yep. And that's why we wanted to have you on today, because at Astron, what we do, we want to position it as one thing. And this integration of what you're talking about it's a tool. It's another tool that patients have access to, but we never want to position it of course, as the only tool. And you're the same way, right? Standard of care obviously has its position, but there's so many ways to improve its efficacy and reduce its side effects. And this is the kind of thing that just empowers people, because that loss of agency when you get that diagnosis and you get that short amount of time with an oncologist, and then the amount of, the intimidation of if you are proactive to going on the internet and trying to sort through all this is brutal. So, and so with that, we have our chief science officer on here, Sam. He's the kid in the candy store that you referred to earlier with all this data.
Nice.
Absolutely brilliant. And he's going to introduce what's called the newest iteration of what we're doing here called the Polaris Report.
So
I hope he's still on here.
You.
Yeah.
there he is.
I am, unfortunately for you, I am still on. Thanks, Trav and Nasha, of course. I think, yes, speaking to Trav's point, essentially what we're trying to do at Astron is help clinicians and their patients leverage the information that, as Travis says, already exists in many cases, especially in the US, where molecular testing has essentially become standard in at least many healthcare systems. What we're essentially trying to do is take all that information that's there that is completely unused, and by accessing essentially the entire corpus of published scientific information, all of the network analysis studies that have been done, all of the clinical trials that have been run since time immemorial to try and surface that information for clinicians so that there is additional optionality for their patients. And that might include FDA-approved drugs. It may include, FDA-approved oncology drugs. It may include FDA-approved drugs for other indications. So like metformin, this diabetes drug that Travis was talking about. It may include supplements, or it might include lifestyle interventions that can be made, whether that's associated with diet, whether that's structured exercise training, or whatever it is. If there's robust evidence that it will work in a patient population that's characterized by the molecular alteration that is essentially present in a given patient, then we surface that information to clinicians. And as Travis had said, what that means is that rather than only being able to engage that sort of 7% of these genetic drivers, the big budget drivers that affect, a fairly large proportion of the population of cancer patients, it means that there are options for patients who aren't fortunate enough to have cancers that are driven by these high priority genetic drivers that can make billions of dollars for pharma companies. And as well, it provides options for those patients who are lucky enough to engage other pathways, such that rather than just applying a selection pressure to their tumor and forcing that tumor to essentially leverage other elements of its genome for survival, we can try our best to stop it in its tracks by taking advantage of this entire pharmacopoeia. So what I'm going to do is walk you through essentially how we formatted this information. We call this report Polaris, Polaris being the North Star, and we would like to think that this is a way to guide you through essentially precision oncology treatment for any patient. And I would just share my screen. Here we go. This is a de-anonymized report. And in this patient, I think the first thing we'll highlight, and then I'll scroll up to the top of this report, is that alteration burden on this patient is fairly high. I think from memory, this was a breast cancer case. And you'll see that there's a lot of targets. I'll make my screen slightly larger here. You'll see there's a lot of targets which have alterations present in them. There's going to be a lot of information contained within here, but essentially, when I look at this, I see that there are really 3 or 4 things happening in this patient's tumor. The first thing is that essentially the genes responsible for tumor growth, many of them have been altered in this case. So that would be things like TP53, which is involved in genomic stability. This tumor can essentially evolve quickly. It can avoid death and it can grow, and it activated those programs for growth. mTOR, which is involved in metabolic regulation. So this is a metabolically dysregulated tumor. Beyond that sort of those elements that are maybe helping grow, the CDK1 as well. There's also survival mechanisms that are activated. So that'd be BERK5, which produces a protein conveniently called survivin, and BCL2, which is involved in sort of natural cell death. And then the sort of last thing, and I've touched on it with TP53 there, but also you'll see down here, BRCA1, there's a loss of function here. And what that means is that this tumor is very, very capable of creating additional genomic instability in the future. It's going to be able to evolve. And because of that, it's going to be able to adapt to single treatments that you throw at it fairly readily. And so the takeaway here is that really there are 4 paths we can take to address this tumor and try to prevent it from leveraging all of these different dysregulated pathways and parts to try and stop it in its tracks. And so the way we present this information is the first thing we do is we've analyzed all of these targets, and we've analyzed every single drug that and treatment intervention that may be non-chemical. And we have ranked them based upon a few factors. One is how much evidence is there for the drug benefiting patients with this particular alteration. The second is how much confidence do we have that drug is achieving its goal through direct interaction? So essentially, is this likely to translate well in a patient who has quite a dysregulated tumor? Because we are essentially directly hitting the protein that is responsible for the cancer achieving its goals in this case. The other is actually how important are each of these targets? There's a lot of targets present here, but you can only put a patient on so many therapies. And so we want to prioritize therapies that are engaging those targets that are really at this exact moment in time responsible for the cancer's current trajectory, evolutionary and growth trajectory. And the last element really comes down to sort of the approval status of the drug. And the reason we've done this is there tends to be more evidence for a specific treatment having a benefit in a patient when it's made its way up the evidence pyramid. So if we're taking a natural product that's just, found in, I'll use an example other than caffeine, because there's a lot of evidence for the use of caffeine, that's maybe found in peanuts, for example. And we've seen some spurious correlation that there's benefit for patients who consume more peanuts than others. That may not translate as well as when we looked at, or when we've got data sourced from a particular clinical trial that's been run robustly, it's well controlled for 1,000 or so patients, and that drug has either ended up being approved for cancer or has been approved in another indication. So we also know it's safe. So those are the four factors, and they essentially are collated into what we call an Astron score, which for all intents and purposes is just a ranking mechanism. Now, in this case, this patient is HNRD, so homologous recombination deficient. They have this BRCA1 mutation, and so really the highest priority treatments that could be taken for this patient, probably to put them on a PARP inhibitor, which works via this mechanism called synthetic lethality that Travis talked about. There's a few options here, and we've ranked them based upon the evidence tied to them. We can look into that evidence more deeply in a moment, but initially we've broken it down by BRCA1 is very heavily involved in this cancer. So it gets a G-score, a gene score of 73.38. The drug is approved for patients with this specific genotype. The evidence surrounding the use of this drug is really robust. There's a ton of clinical trials. There's a ton of preclinical evidence in mice, in cells, in non-human primates to show that we are essentially seeing response to this drug in a very large proportion of patients with this exact genotype. And then lastly, the binding score here really relates to that translatability. It's that this drug achieves its goal by it interacts with BRCA, but it isn't interacting directly with BRCA. It's interacting with PARP, as I mentioned before, which is a synthetic lethal gene pair with BRCA1. And therefore, if there is an issue with PARP that we are unaware of, that hasn't been flagged in the molecular testing, we may not see translation of benefit to this patient. Because the only information that we have with respect to this pair in this case is that BRCA1 has a loss of function mutation. But I think that the more interesting stuff, we can get away from the FDA-approved drugs. Most oncologists would probably, if they saw a patient like this, put them on BRCA1. But how can we engage those other pathways where perhaps there aren't FDA-approved oncology drugs? And the first thing that pops up here is metformin, a drug that Travis has already talked about, which, because it is involved in essentially altering the regulation of sugar metabolism, it affects a ton of stuff. It affects a ton of targets. And so it pops up as a repurposed drug for a lot of indications. But in particular here, where we have this mTOR altered tumor, we found that in patients with essentially that background, that they often see substantial benefit from using metformin because it supports essentially the alteration of the cancer's metabolism, pushing them away from that readily available sugar, which cancers, as I think both Nasha and Travis have said earlier, are really very much dependent on in many cases. And essentially, by reducing the availability of that sugar, essentially slows down their capacity to grow. And we also see here that, as I mentioned, because metformin affects metabolism, it affects a large number of targets, and we see that there are a large number of biomarkers for its effect. But also in patients who are TP53 deficient, we see benefit there as well. We also see that it engages BCL2, which is in a synthetic lethal pair with TP53, CDK6, CDK2, EZH2. And so by using this one drug, we can actually engage a huge number of those targets that we saw down below, both directly, indirectly, and through pathway effects. And so metformin ranks particularly highly in this case because we are going to be able to engage both that aberrant growth, but also the dysregulation of sort of genetic repair. And so the cancer's ability to evade cell death, and then also growth. And then also another couple. So sirolimus is rapamycin. mTOR stands for the main target of rapamycin. It's used to prevent rejection of transplants. And and has shown some benefit in cancer. So the evidence score is a little bit lower than for metformin, but once again, we're engaging a really robust target. There's a lot of evidence for this drug being provably safe and having some evidence in cancer. And we know it engages directly to mTOR and then caffeine, which in this case, once again, has actually been shown to directly bind mTOR, but is actually probably achieving its effects indirectly. So the first thing we do is we surface that information, those sort of the 6 best options, so clinicians can make quick decisions to either validate their own thoughts around using FDA-approved drugs in the case for this patient, or other essentially supplemental adjuvant treatment options that could be leveraged in this patient. And we try to surface things that are both could be used by oncologists, but can be used by naturopaths as well, and as well as integrative oncologists. Now, if you want more information, and I'm sure for many people you do, for many people, you might be busy and you just want those highest evidence options, we also break things down by target. And so here we can go into TP53 and we can look at all of these options that achieve an effect on TP53 mutant cancer. In this case, viral pathway member, so that would be chloroquine. And if we click here, we can see an explanation of actually, essentially, why might this be a beneficial treatment option for a patient? Why is TP53 important to tumor growth? How sort of provably safe are these drugs? Have they been approved in other indications? Are they approved in cancer? Are they preclinical? So that's under this D score. The evidence, this is a collation of all of the literature that we've managed to pull, and we can access more information by going through the supporting evidence tab, and then also the binding information if there is any. And we pull both experimental data, and we also have a machine learning model that can simulate the direct interaction between drugs and targets to try and build up that core evidence base to facilitate translation. And TP53 traditionally can't be engaged. There are no drugs that directly engage TP53 loss of function, because TP53 loss of function means it's not functional, it's not there. But what we can do, as we said, is engage indirectly via pathway members, interaction partners, and also using synthetic lethality, which is this premise that essentially there are 2 genes buffering each other, and if we can turn off both of them, it causes cell death, but if only one of them is missing, the cells can function fine. So in this case, if we were to treat a patient with raloxifene, which affects BCL2, only TP53 mutant cells will die. And so there should be minimal effect on other healthy tissue. And then, we have a lot more detail here on all of these targets. Some of them will be engaging directly in the case of mTOR. Some of them, like TP53, those tumor suppressors, were engaging indirectly. But what we're doing is providing optionality in a ranked fashion, such that you as a clinician can go, actually, we want to directly inhibit growth. We want to directly inhibit that DNA, the DNA repair errors. And we also want to facilitate more effective apoptosis, so that the body's natural means to sort of destroy cells. And so we maybe want to engage TP53. And we can use some of those options we've looked at momentarily a moment ago. We want to engage mTOR, so we can choose the highest ranked options here. In that case, metformin, maybe sirolimus. Caffeine, because it's cheap, it's available over the counter. It doesn't require too much to have a couple of 3-4 cups of coffee a day. And then also we want to affect survival. So maybe we'll choose BCL2, so maybe raloxifene, which also is engaging TP53. Or we might want to engage BERK5 in this case. Berberin's our only option. It's not got a huge amount of evidence, but once again, it's a broadly available supplement that is not particularly expensive and doesn't have many side effects on patients. And so using this tool, you can essentially develop a treatment protocol tailored to your patients in a way that is, we'll say, directed, and surfaces all of the evidence for the use of that particular treatment in that particular patient. We've tried to make that as essentially as easy as possible for every kind of clinician. I hope that is helpful and interesting, and I'm sure I can take questions at the end of the session.
May I just add kind of just a clinician input here? So first of all, again, this information is game-changing for so many, because we don't have the time as clinicians to go down and mill all the data. But what we mostly meet are patients who come in on bucketfuls of supplements, off-label drugs, and self-prescribed, that have been self-prescribed, or they've followed some good, because I saw a lot of comments in the background here. That actually, in my world, has created more harm than good. And then as a clinician who thinks terrain-centric, I also want to look to make sure their pharmacogenomics can meet these medications well. I also want to look at the patient's current other comorbidities or other health issues that are going on. Like if they've got extreme anxiety and cardiovascular issues, maybe caffeine isn't going to be a really good fit, So we have to always remember, you have to put the patient first. Our seduction, and I already see it showing up in the chat and the Q&A here, is that we just think there's the treatment, there's my golden my golden pill. And so it will only, these therapies that Astron is able to test will only be received by how well the terrain is ready to receive it. And so I just want to preempt that, because I've watched a ton of people come in who've thrown everything from their Astron reports or other evaluation reports like this at environments that can't tolerate it or can't receive it or backfire because no one took the time to understand the environment in which these treatments were being placed. So I just want to put that out there. I feel like I have to do my due diligence as a clinician to say, please don't think that it's the drug that's doing all the work. It's how well the drug is received in your body at any given time.
Yeah, and Nasha, I want to expand on that, right? That again, as we position this as a tool for where this hard data meets the art of medicine. And in Curable, the second book I wrote, we talk about the misuse of data or the underutilization of data in medicine, which is profound. You see huge variable from one county to another. You see variation in treatment. So the biggest tendencies are variation in treatment and overtreatment in general in medicine. And the end, what I left with was the perfect compromise comes from chess, where you can have a computer that is insanely good and can beat most humans. This was back when it just, it wasn't as good as it is now, but they came up with something called total chess, where a human chess grandmaster would have work with a computer. And that was the best combination by far. They learned the instinctual ability of the person to learn what the computer model was doing was better than any computer or any human by itself. And I thought that was a perfect metaphor for what this is, where that intuition, you always want to have that with a clinician, what you do, right? Where this data tool meets that sort of brilliant intuition and art of medicine.
Perfect. Thank you for that. I love how you phrase that. Cool.
So you want to do any questions, Raf?
Yeah, sure. We can run through a few questions. We only have 5 minutes on the call. There are a few hard stops. Just scroll to the top. Start looking at a few questions. Let's see. I think I guess one of the first questions that we're looking at is like one question that Michelle asked, actually, or James asked, is, how can you get this kind of reporting, or like how does a patient access a Polaris report? And Trav, I'm not sure if you want to answer that, or I can get into that.
Yeah, go ahead, Raf.
Yeah, essentially within the US, there are a few partner clinicians that are partnered with Astron. And as a result, you need to have a consultation with them for them to review the next generation sequencing tests that you've that are currently specific to your case. And then from there, the clinician, once they look at the test results, and if they find that you're viable, will order a Polaris report to interpret and create that personalized treatment protocol for you. I think another question that I think Sam probably answered this, but it'd probably be great for Sam to answer this again out loud, is essentially, Izzy asks, do we look at efficacy of combinations for different drugs or supplements?
Absolutely. So I think I answered it very briefly in the chat, but essentially what we're working on at the moment is how we can better model the interactions of these drugs. Such that we can essentially facilitate engagement across multiple nodes, across all of these pathways, with as few drugs as possible. When it comes to toxicological events associated with the use of combinations of these drugs, that's something we're currently flagging. But beyond the actual modeling, that is sort of an active research avenue we're working at the moment.
Awesome. Maybe another question actually from Ella is what value is there for patients who have no clinician who is willing to incorporate the findings from the research report? And also, like, have you found that oncologists deviate from their standard of care protocols?
You want me to tackle that one?
Yeah, you're perfect
Very
for that,
briefly.
Nation.
Yeah, I mean, number one, sadly, there's not enough oncologists who will use this data, but I'm really hopeful that what Astron has done with this report is that they're speaking more the language of the conventional oncologist than the quote unquote integrative oncologist. So my hope is this might warm them up and give them a tool to use readily in their own clinical practices. So my hope is this actually will change that dynamic. So that's when I started seeing the benefit there. This actually might change conventional oncology. And then specific to whether you should take this information and use it on your own, I would personally never recommend that. I think just hard stop, and that you really have to take this information into context, and you have to work with someone who understands these medications and interactions, and also your pharmacogenomics and the rest of your terrain to bring that in together. This is not a self-guided tour, would be my 2 cents there.
Awesome. I think there was another question maybe for the wider panel about like what is the testing required? Like what is this molecular testing or next generation sequencing testing? Like how could these patients typically find out whether or not they've had this test already done on them?
I mean, Travis said it earlier, about 85% of patients today have had this type of testing done, maybe at the very original biopsy, and have this data stored somewhere unbeknownst to them. So they can simply go back to their clinical team and ask if they've ever had any NGS testing done ever on their process. Then they already have something there that they can work with. And if they haven't, they can request that of their oncology team as well.
We also can connect you with clinicians who might be able to support you in arranging testing. As a sort of, for the sake of clarity, we ourselves do not do testing. We analyze molecular testing results. We will never take a cut of the cost of any testing that we facilitate you arranging or that you've used. So regardless of whether you've had testing done on blood, whether you've had it done on a tumor, a biopsy, we can work with any genomic testing, any transcriptomic testing, any proteomic testing to identify potential treatment options for your patients or for yourself.
Very cool. That's really expanded the field, because you used to only have a few that you could work with, but it seemed like you guys have really made it very agnostic, which I think is very important, because we have a lot of, like we said in the very beginning of this conversation, there's a lot of people sitting on mounds of information that's been underutilized. And I think that this sort of opens it up again, where people don't have to go to the great expense of a brand new test to do something. You might already have something that you can work with already.
Exactly. And an active avenue of work, or avenue we're working on at the moment, is around bringing down the cost of testing. Obviously in the US, in most cases, it's at least your first test will be covered by insurance, but ex-US testing is less standard. And so many patients have to pay out of pocket. And, it can be sort of £2,000, £3,000, £4,000, which is exorbitant. So we're working with partners at the moment to try and bring that down as low as possible, such that essentially testing can become standard practice outside of the US. And so that, there's more of a case for more regular testing. So rather than an insurer paying $4,000 once, maybe there's a case that you could have testing every 3 months, every 6 months, every year, such that we can monitor tumor development and adjust treatment protocols based upon how, treatment plan 1 has affected the evolutionary trajectory of a cancer.
Interesting. Cool.
I think we're running a bit over, but just one final mini question. Have there been considerations for integrating gut microbiome testing by any chance? I know we're looking at the things from a multi-omic point of view, but where would that lie in future plans, Sam or Travis, or even Dr. Nasha?
Well,
I think Nasha's the one to take the microbiome.
well, I'm just hopeful that it does get more looked at. I mean, I think it really is an untapped, frontier in medicine to help us understand how we respond to anything we put in our bodies. And I think it can really enhance the efficacy of many of our treatments, conventional or otherwise. So my hope is that we're still not there yet with perfect microbiome testing. And I think that's something that continues to be, evolving and iterating as we speak. So hopefully someday this will be something we can take into consideration.
Awesome.
Cool.
Well, thank you so much, guys. It was a really interesting session. I learned a lot. And thank you so much again to Nasha and Travis for a fantastic conversation. Thank you to everybody who's joined us today. If you're a patient or clinician interested in learning more about how the Polaris Report can support your care or practice, you can go to our website, www.astron.health. And also we'll be sending over the recordings for this session, as well as more information within the next 24 hours. Thanks again, everyone. And
Thank you.
I hope you have a great
Thanks
rest
for
of your day.
being our personal research assistant. That's what I look at this as, because this is a personal research assistant. So thank you for that.